good afternoon to all of you today. Thank you for joining us. This is the Road to Recovery, and it's a program primarily intended to help caregivers with various aspects of mental illness or with the experience of mental illness and caring for those with mental illness in their lives. Just some very quick etiquette before we go on. We'll have two presenters today, and Dr. Krish Prasad will introduce them shortly. And I'd request you to keep your while the presentation is ongoing, and then when you have an opportunity to ask questions, and when we take a break, I request you to please introduce yourself before asking your questions. And if there are questions you have in between, please put them in the chat, and we will take them up. But we would encourage you to ask your questions by asking them, turning on your mics and asking them when the opportunity arises. So again, very quickly, good afternoon to all of you. I'm Dr. Deepak Jayarajan, and this program is organized by the Psychiatric Rehabilitation Services team, many of whom are on. But I'll particularly hand it over to my colleague and friend, Dr. Krishna Prasad, who will be a facilitator for this afternoon, and he will introduce the speakers for the program who are going to deliver a very important talk to us today. Thank you. KP, over to you.
Thank you, Deepak. I think we have a very important topic that we thought would be relevant to caregivers and service users at psychiatric rehabilitation services, and also people who are using these services elsewhere. So we thought we will have people who have experience of handling these problems firsthand. And the topic is basically tobacco cessation in persons with severe mental illness. So it is our pleasure to introduce the two resource persons today. So we have Dr. Lekhansh Shukla, so as the first resource person, and warm welcome to you, Lekhansh. And just to introduce Lekhansh, Dr. Lekhansh Shukla is an assistant professor in the Department of Psychiatry. He works specifically in the Center for Addiction Medicine. He is a graduate of Gandhi Medical College, Bhopal, and has done his MD and DM from NIMHANS, and I think had a brief stint in AIIMS Bhopal, and subsequently has joined as a faculty at NIMHANS. So his experience of working in addiction medicine will be harnessed today. And we have Mr. Sudarshan Hegde, who has been having an experience of working with mental health services for the last 10 years, and he specifically comes with his experience of working in the quitline services as a supervisor in the quitline services that is run by NIMHANS. So welcome to you, Sudarshan, as well. So without much ado, we'll ask Dr. Lekhansh to start, and we'll probably take questions at the end of presentations, first by Lekhansh and then by Sudarshan. So over to you, Lekhansh.
Thank you, sir. Thanks to the whole team for inviting me. So I believe it must be visible now.
Yes, it is, Lekhansh.
Thank you. Thank you. So good afternoon, everyone. Sir has already introduced, KP sir has already introduced me. So I'll move ahead with the topic. Before that, I just wanted to communicate that I am not a Kannada speaker. So ನಾನು ಕನ್ನಡ ಈಗಲೂ ಕಲಿಯುತ್ತಾ ಇದ್ದೀನಿ, ಬಟ್ ನಾನು ಪ್ರಯಾಸ ಮಾಡ್ತೀನಿ ಸ್ವಲ್ಪ ಮಿಕ್ಸ್ ಮಾಡಿಕೊಂಡು ಕನ್ನಡ ಇಂಗ್ಲಿಷ್, but my aim would be that the message gets across. If I get stuck at some idea which I cannot express in Kannada, I'll ask help from KP sir to help me with that. Before we, ಒಂದು ಓವರ್ವ್ಯೂ ಕೊಡಕ್ಕೆ ಅಂದ್ರೆ ಈ ವಿಷಯ ಬಗ್ಗೆ ಮಾತಾಡಕ್ಕೆ ಇಂಪಾರ್ಟೆನ್ಸ್ ಏನಕ್ಕೆ ಇದ್ರ ಬಗ್ಗೆ ಮಾತಾಡಬೇಕು, ಏನಕ್ಕೆ ಇದೆಲ್ಲ ಅಷ್ಟೊಂದು ಇಂಪಾರ್ಟೆನ್ಸ್ ಕೊಡಬೇಕು ಅಂತ ಅದು ಫಸ್ಟ್ ನಾನು ಡಿಸ್ಕಸ್ ಮಾಡ್ಕೊಡ್ತೀನಿ. ಆಮೇಲೆ ಒಂದು ಮುಖ್ಯ ವಿಷಯ ಸ್ವಲ್ಪ ಇಟ್ಕೊಳ್ಬೇಕು, ಇದು ತುಂಬಾ ಡಿಫಿಕಲ್ಟ್, ತುಂಬಾ ಕಷ್ಟ. ಯಾವುದೋ ದುಶ್ಚಟ ಬಿಡೋದು ಕಷ್ಟ, ಅದ್ ನಿಜ, ಬಟ್ ಸ್ಮೋಕಿಂಗ್ ಬಿಡೋದು ತುಂಬಾ ಜಾಸ್ತಿ ಕಷ್ಟ. ಸೊ ಈವನ್ ನಾರ್ಮಲ್ ಈವನ್ ಪೀಪಲ್ ಹೂ ಡು ನಾಟ್ ಹ್ಯಾವ್ ಎನಿ ಮೆಂಟಲ್ ಇಲ್ನೆಸ್, ಅವ್ನಿಗೇನು ತುಂಬಾ ಕಷ್ಟ ಬರುತ್ತೆ. ಸೊ ಅದ್ ಏನಕ್ಕೆ ಬರುತ್ತೆ ಅಂತ ಡಿಸ್ಕಸ್ ಮಾಡ್ಕೊಡ್ತೀನಿ. ಯಾವ ಟೈಮ್ ಚೆನ್ನಾಗಿರುತ್ತೆ ಬಿಡೋದಕ್ಕೆ, ಏನೇನ್ ನೋಡ್ಬೇಕು ಅಂತ. ಅದನ್ನು ಸ್ವಲ್ಪ ಡಿಸ್ಕಸ್ ಮಾಡ್ಕೊಡ್ತೀನಿ. ಆಮೇಲೆ ಆಫ್ ಕೋರ್ಸ್ ಯಾವ ರೀತಿ ಬಿಡ್ಬೋದು, ಯಾವ ರೀತಿ ಸ್ಟಾಪ್ ಮಾಡ್ಬೋದು ಅಂತ ಅದು ಮುಖ್ಯ ಡಿಸ್ಕಷನ್ ಟಾಪಿಕ್ ಇವತ್ತು. ಓಕೆ, ಸೊ ಕಮಿಂಗ್ ಟು why is it important? I'm sure everybody knows, but if you look at it, last 20 ವರ್ಷದಿಂದ usual population smoking has almost halved. Okay, so there were 1,000 people in a place who were smoking earlier. Now there are only 500. ಅದ್ ಕಾರಣ ಏನಂತ ಸ್ವಲ್ಪ ಅವೇರ್ನೆಸ್ ಬಂದಿದ್ದಾನೆ, ತುಂಬಾ ಗವರ್ಮೆಂಟ್ ಗಳನ್ನು ತುಂಬಾ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ಸ್ ಮಾಡ್ತಾ ಇದ್ದಾನೆ. ಅದೆಲ್ಲ ಪ್ರಯಾಸದಿಂದ most of the people, they have stopped smoking. But ಆ ರೀತಿ ಟ್ರೆಂಡ್ ಮೆಂಟಲ್ ಇಲ್ನೆಸ್ ಇರುವಾಗ ಪೇಷಂಟ್ಸ್.
Likansh, hi, I'm Akriti. Can we only stick to English, because I think a large population here may be able to converse and understand English largely, unless you say that people with Kannada background are also here. Would English be sufficient for everybody?
I am actually going by the introduction that I had, so I'll leave it to the organizers.
I think a lot of people in the audience will be are English speaking.
Likansh,
so
I think we can go ahead with English, and if there are people who want, we can always clarify.
We can always clarify in Kannada. Okay, thank you. Akriti, you kind of made my job much easier. Fine. So, as I was telling, over the last 20 years, most of the people have who were smoking earlier have undergone a phase where they have accessed services, or even without any consultation or without any help, they have stopped smoking. There are multiple reasons for it, one of which is an increase in awareness. But across the world, and this is not only for India, across the world, we have not seen a similar kind of decrease in tobacco consumption by whatever form in people who do have mental illness. Another reason why we need to talk about it is, if you actually look at data, and this is something that people who have been in the field for some time know, the average life expectancy of patients who have a severe mental illness is much, much lower than the general population of that country. And most of that load, or most of that early mortality, actually comes from heart attacks, strokes, and as you already know, tobacco contributes to most of it. One more important thing that we need to consider is, especially for illnesses like schizophrenia and psychosis, tobacco use can actually decrease the effect of some medicines, and then the psychiatrist or whoever is the treating team has to increase the dose of medicines. We know every time there is an increase of dose, there is a higher risk of adverse effects. There are some small behavioral things. For example, a lot of patients come with complaints of insomnia, and when you look at it, there are already so many medicines which must be helping them with it. But then they are smoking in the evening, they are smoking in the night. So of course, we do know that tobacco increases alertness, and therefore it causes problems with getting sleep. Many a times, tobacco use can also be a reason for poor marital and family relations. And you see this in terms of a lot of people are very aversive to tobacco use in whatever form. And of course, if somebody is smoking, there is a stink to it. If somebody is using oral tobacco, there is a poor oral hygiene, and all these things can actually interfere with complete integration of the individual in a normative stream. So these are the reasons why I think it is quite important. Why is it difficult? And I say this quite categorically, the success rates of tobacco quitting without any help are really very low. So it's a difficult thing for everybody who has been smoking or chewing tobacco for some time. Why is it all the more difficult for people with mental difficulties is when anybody who has been using tobacco for a long time and then they want to stop it, they undergo for next 6 to 8 weeks something that we call a withdrawal syndrome. And this is quite prolonged. So 6 to 8 weeks is, we are talking of almost 2 months. And the symptoms of it are irritability, low mood, constipation, the hunger increases quite a bit. And just imagine if somebody already has some mental difficulties, problems with mood, problems with activity, it becomes all the more difficult for them to endure this whole withdrawal syndrome for about 6 to 8 weeks. We must also remember for a number of patients, tobacco may be helping with some side effects of the medicine. For example, some medicines cause too much saliva secretion, and smoking actually decreases saliva secretion. So it may be helping with a side effect. A lot of medicines cause excessive hunger. Smoking and oral tobacco both decrease hunger. So it may be helping them with some side effects. And that's why they may find it difficult to quit. And these are things we must keep in mind. Tobacco relieves boredom, as we know, and as is the, as is the dictum in rehabilitation. Patients with mental illnesses who otherwise are fit to be doing something are very many times are doing nothing. So they feel very bored, and tobacco relieves this boredom. Tobacco has a direct effect on one's mood and the speed of functioning. And one does not have to be an addict. One does not have to be using it for a long time to experience it. Even people who have never used tobacco, if they take tobacco, their mood improves a bit, their speed of processing, their concentration, all that improves a bit. And we know these are some symptoms which are common to most of the severe mental illnesses. So tobacco might actually be serving a medical role here also for them. Coming to, having said that, coming to when is a nice time to attempt it. Actually, if you go by what the dictum is, any time is good time to try and stop an addiction, especially tobacco use. But practically speaking, and this is what I have experienced, very many times one's attempt to stop using tobacco are not successful because the timing was not right. So to an extent, one must look for a time when the symptoms are relatively controlled, because if the symptoms are very marked, it may be difficult to explain the whole process. It may be difficult for the patient to cooperate. Another thing that we must keep in mind is irritability is a most troublesome problem during withdrawal. So the caregiver must also be mentally prepared for some tough days ahead. Of course, treatment must be available. I know for a long time, the whole philosophy was it's a habit, just stop it. You will experience problems for next 2-3 weeks and then you will be victorious. But at least for people with severe mental illness, we now know that the success of unaided, that is where no help was given to the patient, the success of such kind of quick attempts is really low. It may also be a useful thing to consider if there's some other caregiver around who can help if there is worsening of patient's mental condition. And it would be very helpful if the patient is already engaged in some sort of a structured day or supported employment. Those would actually help the patient's success rate. It is found all over the literature that one has teachable moments, so-called teachable moments, when people are admitted for other illnesses, not necessarily for psychiatric, or when they have just enrolled for a rehabilitation program, they have started going for day boarding. What happens is the environment at this time itself makes the patient to smoke less. So these are really good teachable times where you could actually then discuss with the patient about, okay, you have already stopped smoking for 6 hours a day, or you have already stopped smoking completely for last 7 days that you are in hospital. Why don't we continue this and let's discuss what are the problems that you are facing. Now coming to how to attempt it. I think the core message of this presentation is you have to be gentle but persistent. What I mean by gentle is you should try to avoid making it a point of conflict, because if that happens, then of course cooperation goes off. But you have to be persistent. So I would say you don't have to nag, but you have to keep this conversation going, even if you feel it's not reaching anywhere. Earlier, there was a thought that cut to quit, that is decrease the number of times one is smoking or is chewing tobacco before planning to quit, is not a very helpful strategy. But we now have evidence, especially for people with severe mental illness, that it's a very reasonable strategy. It gives them autonomy, it promotes their self-efficacy, it promotes their belief that they can actually do it. So I think a reasonable point to start is to actually request the patient to engage in a conversation about, can you reduce it? And then take it forward to, okay, now that you have already reduced it so much, why don't we talk about stopping completely? I am not going into details of treatment options for it. I believe that would require a different kind of a presentation altogether. But briefly, there is, you can take preparations, or you can take things that could give the nicotine through the mouth. And those are pastils and gums. There is some evidence that pastils may be more effective than gums. Many of you would have seen ads of these things. To make it more clear, pastil is something which you suck on and it eventually dissolves completely. Whereas gum is something which has to stay in your mouth for a long time, and then you have to spit it out once you are done with it. Another route of supplying nicotine to the body for some time is using a patch. So this patch looks like a transparent bandage. This has to be applied one patch every day. And it is believed that it is much more effective than oral preparations like pastils or gums. A combination of the two might be even better than either one of them. Because what patch does is, it keeps giving a certain amount of nicotine throughout the day, 24 hours a day. Still, patient may have periods where, for example, in the morning before using the loo, or if you speak to any smoker, not only patients with severe mental illness, the first smoke in the morning and the smoke after having food are two which they find particularly difficult to leave. So it may not be a bad idea to use patch along with gums and pastils. You can also use certain other medicines. Two of them are bupropion and varenicline, along with any of these strategies. And this kind of a combination would be the most effective way of treating nicotine dependence. We'll see what are the problems with those oral medicines. So to give a broad overview, how do you go about it if you are a caregiver for somebody who has a severe mental illness and is struggling with tobacco dependence? The first thing to do is speak about it. Very many times, the pattern that one gets if you take a good history is, yes, at that point we were talking about it, then we got into a fight about it, then I decided, okay, this will not work. He will keep doing it, sir, what to do? So that is something we need to avoid. We need to keep talking about tobacco as a problem. Let it be on the horizon. This kind of prepares the ground for reducing tobacco use. Start keeping a count. Very many times the caregivers and even patients do not have a count of how much are they smoking, because this has become such an automatic activity. Just like you would not very easily remember how many glasses of water you drank today. Similarly, they kind of lose count. So it's a good idea to keep a count and keep reinforcing that, okay, I'm not asking you to quit. I'm just asking you to reduce right now. Once reduction starts, one must add some kind of a replacement. So add gums, pastils, or patch. And a good starting point is to tell the patient, every time you feel like smoking or chewing gutka, which you were doing till now, use this preparation that I'm giving you and see, does it help you cut down further? Does it help you substitute completely? Can you shift yourself completely from what you were using earlier to one of these medicines? Once that has come, once that stage has come, then that is the right time to start discussions about quit date. So this whole concept of quit date is that the patient is allowed autonomy to decide, okay, after this particular day or after this particular date, I will throw off all my cigarettes, all my gutka, whatever I was using, and that is my quit date. I will not smoke after it. So then you must actually bring the patient to that stage before you have that kind of a discussion. Once the quit date is decided, you give whatever medicines that your doctor is comfortable in giving. It might be a combination of things, and keep motivating for a quit date. So finally, the quit date is set and it arrives. Two of the things could happen. One is the quit date came, the patient stopped for 1 or 2 days and then lapsed again. No harm in that. And I will discuss why I think it's not a bad outcome. You take them back to the earlier stage where you give them full treatment and again motivate for a quit date. I also want to underline, if the patient has quit for a substantial period, and substantial period is about 2 weeks or more, you must inform your doctor, because as I said, tobacco use decreases the effectiveness of medicines. So automatically, not automatically actually, keeping this in mind and seeing the response, the doctor might have increased the dose of some medicines. And now that the smoking has stopped, this dose will be too much of a dose. So you might find that after stopping smoking, after about 1 to 2 weeks, the patient is getting too drowsy, a lot of side effects are appearing. In that case, you must consult with your doctor. If the quitting is if the quitting has failed, I have already discussed it. If the quitting is successful, I told you, please inform the doctor. You may end up in a stage where the patient has reduced substantially or has completely transferred onto some form of nicotine replacement, but is not willing to quit completely. Well, that is okay. That's okay. Just carry on the conversation about, okay, now how do we stop the last 2 that you are smoking? Or how do we now think of decreasing the number of gums that you are taking every day? How many times to attempt? So as I said, failure will occur. It will not a question of failure may occur. It will certainly occur. The answer to that question is as many times as necessary. And one way to think of it is, see, nobody gets addicted or dependent, whichever word you prefer, after using for 1 day or even for 1 week or even at times for 1 month. Similarly, nobody comes out of that habit in 1 attempt. Multiple attempts are required. And actually, if you look at it, even people who do not have a severe mental illness have to make about 6 to 8 attempts before they actually become successful. Okay. And although I do not have a specific reference for it, I do believe that this number would be twice for people with severe mental illness because they find the withdrawal quite difficult, cooperation may not be optimal, things like that. The good news is the more the number of past attempts, the higher the chance of success in later trials. What I mean by that is, if you're seeing a patient who has now come for trying to quit smoking, and if you ask, have you tried it earlier? And he says, no, I have never tried earlier, versus a patient who has already tried earlier 4 to 5 times, the chance of the second patient is much higher because the chance of success keeps increasing with every quit attempt. It frequently happens that you end up in a situation which is partial success. You don't know, do you call it success or not? I'll tell you some scenarios. For example, somebody has decreased cigarettes or BDs from 20 to 2, and rest of the time they are using nicotine gum. To me, this is a good outcome. This is a good outcome, even if it continues indefinitely, because we know there is a dose effect. So when we calculate somebody's risk for a heart attack, what we do is number of cigarette packs consumed into years, consumed every day into years. So even if that number comes down, you are at least doing some benefit there. Another situation, maybe my patient has stopped completely, but is now using gums and are not able to stop it for last 6 months. To me, this is also a good outcome because for all the available evidence right now, these gums and pastils, they do not seem to have any risk comparable to using cigarettes, smoking, BDs, or oral tobacco. A situation might be my patient has decreased it from 20 to 15, so only there's not substantial reduction, and is using a good number of gums also every day. This will require a fine balancing to see why is it that the patient is having to use so much of nicotine per day. Coming to what could be the barriers to success. One of the barriers that I believe, which is especially relevant to us because we are in public sector and we see these kind of patients is, affordability. And if you actually calculate for most treatments, and there is a perception that varenicline, which is one of the most effective treatments, is particularly expensive. Whereas if you actually do a good calculation for even nicotine gums, it is not cheap. It's not cheap. It costs quite a bit. So I have given you an approximate cost for how much it is likely to cost for one course of treatment. But one way of looking at it is to actually think of it in long term. So we do know that because of increased taxation, cigarettes and BDs have become quite expensive as compared to what they were, say, about 10 years earlier. So if you actually look at it and you calculate how much money would have gone, although it would have gone slowly. So what happens is a lot of patients and caregivers feel, okay, so I have to pay this much money today. They would be paying the same or a comparable amount of money in the next 2 to 3 weeks for even their whatever preparation of tobacco they are taking. So this is an important point to keep in mind. But having said that, the affordability is really a barrier, because when people are making their mind up about a change and you tell them, this change also requires a lot of money, they are more likely to say no. So yes, it is a real barrier. Some of the treatments are available for free, at least in our center and very many other centers. The government of India is also running a national tobacco control program, which kind of finances healthcare providers to start a tobacco cessation clinic. Another barrier to success that I usually see, and I'm discussing only about gums, is because this happens to be the most prevalent and most commonly used method today. So that's why I'm discussing about it. One is, very many times it is not explained to the patient what method is to be used for this gum. And the method is made unnecessarily complicated by just reading out the package insert which is there in the medicine. The method is quite simple. You have to explain to the patient, there is a medicine inside this chewing gum. You have to chew it for the medicine to come out. When you chew it, in some time medicine will come out and you will feel a sensation which is like having something which is slightly chilly or which is slightly spicy. Once you get that, now you have to just hold that chewing gum, because now it is releasing the medicine, just next to your cheek, and let it be there till you keep on getting the sensation. When the sensation stops, the medicine has stopped again. Please chew it again till the same sensation comes back, and you will have to keep doing it for 2-3 times with the chewing gum. And then you just spit it out at a hygienic place, or you take care that you are not spitting it out in the public. The number of chewing gums, for some reason, I find that most people are being very parsimonious with it. They are being very stingy about how many chewing gums are allowed in a day. For all practical purposes, as many chewing gums are allowed in a day as the patient feels like. It rarely happens that the patient takes more than 12 or 15 chewing gums in a day. If that is happening, what you should look into is the patient taking it properly? So that is something you should look into. But the chewing gum is not really habit forming or addictive. It's very unlikely that somebody would keep increasing the number of chewing gums every day. So be a bit liberal about it. There are certain side effects which come with using this chewing gum. One of which is a lot of saliva comes in the mouth, because it also has certain flavor. And then one has to keep swallowing it repeatedly, or throwing it out, or spitting it out repeatedly. It can also cause some burning in the chest. That is also fairly manageable side effect. One could give antacids for a couple of days and it is taken care of. There are also some some issues with the attitude. Very many times when you explain that, this also contains nicotine, that's why I'm asking you to use it. The family feels, okay, then what is the point about it? Because he was taking nicotine earlier also. So one will have to just explain to them that this is a step towards getting out of nicotine habit completely. So that's my message for today. In summary, it is important, and it is important in terms of even life or death level importance, because we do know that smoking actually increases the risk of premature mortality substantially. Very many of our patients with severe mental illness are already on medicines that increase cholesterol, that decrease their physical activity levels, that increase their body weight, all of which are risk factors for premature mortality due to cardiac or metabolic causes. So it is an important thing. Treatments are, I would say, they are fairly effective. They are not dramatically effective, but they are fairly effective, and they are quite easily available. But it needs some planning, and most importantly, it needs persistence. If it fails one time, start building the ground for the next time. If it fails again, you keep doing it till you actually achieve success. And I think the doctor and the caregiver or the patient directly, they will have to work as a team, because as I said, tobacco might be helping some symptoms of the illness itself, which may now become more prominent, and the doctor may have to do some adjustment with medicines. The doctor will of course be serving as a source of reinforcement, as a source of praise, to put it clearly. Somebody needs to tell the patient that the patient is actually doing very well, and it requires quite a bit of effort to come out of a habit of smoking or chewing gutta. So that's it for from my side. I'll just stop screen sharing, and I'm happy to answer any questions.
Thanks, Lekhansh. I think what you have emphasized is that there are health and serious physical health effects because of smoking and smokeless tobacco. And I think many of our caregivers would be aware of that. But I think most importantly, you also emphasized that it has smoking in particular has significant effects on the need for medications and the dosage of medications. I think that was a second point that I thought was very important, perhaps from the caregiver's point of view. And what you also alluded to was that it's worth the effort to attempt to quit, but some people may have challenges in abruptly stopping tobacco. So you may also suggest cut down to quit. And there are at least some pharmacological options, some treatment options that are available. Though there are challenges, but I think it is worth the effort. I think that is the message. So we will ask the participants and the caregivers if they have a question or two to Lekhansh. You could also type them on the chat.
But I think there's a question in chat. I think Pooja has a question. Pooja can unmute and ask.
You can unmute and ask as well. Pooja? Yeah, Lekhansh, there is a question which asks about the effect of taking alcohol with tobacco.
Okay. Yes, it's an important question. You will probably come across patients, although not necessarily patients with severe mental illness, who will say that we smoke only when we drink. And when you ask them how often do you drink, and they tell you every day. So yes, the two go together for some reason. There is cultural conditioning. So whenever somebody is drinking, they feel like smoking too. There may be a pharmacological effect also, because we know drinking causes sleep and smoking actually increases alertness. So people might be combining the two to get mixed kind of an effect. All points taken together, unless alcohol is in a very problematic fashion, it is in a disorder level fashion. I believe there is no reason why, if somebody occasionally uses alcohol, their success in quitting smoking might be lower than other people. That's my understanding.
Thanks, Lekhansh, for responding to that. Do we have other questions? You can unmute and ask them. So maybe what we will do then is that we will move on to what Sudarshan has to speak from his experience, and come back to Lekhansh and Sudarshan together to take some questions. So over to you, Sudarshan, and you share your experiences of handling the quit line.
Thank you, sir. Okay, so I'll take a minute to start sharing the screen. Am I audible?
Yes, Sudarshan, you are audible.
Yeah, okay. Sorry, I'm not seeing a screen share option here.
You'll see that at the bottom, Sudarshan.
Scroll down. Sorry, when I select that, it is not allowing PPT to present. It is saying only a PDF.
Sudarshan, you could go ahead and talk even without the PPT. I think that should be fine.
KP, do we have it? Can we
Okay.
share it from the weekend if possible? If we have a copy of Sudarshan's PT?
Sujay, is this available
Yeah,
with
I
you?
have shared.
Yeah.
Okay, does it
Anyway, it's a
matter?
simple thing. Means as
Yeah.
he can take time, so I will start doing it.
No. Give me 1 minute. I'm uploading it.
Sure, sure.
Is it visible?
Yes,
Yes, yes.
Please tell
Okay.
me when to change it. Change the slide.
Okay, okay. Good afternoon, everyone. I'm Sudarshan. I'm a supervisor in National Tobacco Quitline Services NIMHANS. It is a regional tobacco center for southern India. So you can go to the next slide. So I'll be giving a more awareness with respect to the function of how tobacco quitline service works and how it can be play a role in the people who have a severe mental illness as well as a tobacco usage. So the caregivers or the patients whoever is present here can note down this number. This is a toll-free number, which is the National Tobacco Quitline Services that you can reach to. So that is 1800 112356. If you dial this number from whichever part of India, it will connect to a National Tobacco Quitline Services. So it is available in most of the Indian languages, and you can go to the next slide. Yeah, so there are four regional centers throughout India. So in north, it is in VPCI, that is Vallabhbhai Patel Chest Institute, Delhi, and in south, of course, it's in NIMHANS, and in northeast, it is Barucha Cancer Institute, it's in Guwahati, and for the west, it is a Tata Memorial Hospital, Mumbai. And NIMHANS Center started in NIMHANS, and all other three centers except VPCI started in 2018 September. VPCI started almost 1.5 years earlier. So VPCI started with initially the National Tobacco Quitline Services itself started with English and Hindi services. So at that time, VPCI started. And after that, after its success, the all other regions, it is expanded with a regional language support. Go to the next slide. Okay, so National Tobacco Quitline Services NIMHANS is catering to the southern part of India. So here we provide a counseling to the people in regional languages. So we provide Kannada, Tamil, Telugu, Malayalam, English, and Hindi. In all these 6 languages, we provide a counseling. So this service is available 8 a.m. to 8 p.m. and Monday is a holiday. So we provide a counseling to the people who wish to quit tobacco, and also the family members or caregivers also can call and understand how they can become a support system to the people who wish to quit tobacco. Next slide. Yeah, so how the National Tobacco Quitline Service can be play a role in road to recovery for the people who wish to quit tobacco, as well as they have severe mental illness cases. So here, the people who wish to quit tobacco calls at the first time by seeing the number. So usually this number is displayed in all tobacco products, both in a smoking form and chewing form. In both the products, they can see that to quit, they can call this number. So that is largely displayed on all the tobacco products. So when they call, so in the first call, we take a assessment and we try to understand what is the tobacco usage, everything. And then a very brief counseling will be given in the first thing. So we try to assess what is the severity and what is there any other comorbidity. All those we assess in the initial stage. Then we do a brief counseling, and we insist them to set a quit date. As Dr. Akansh said, it is very important to set a quit date. Usually we say that from the first call, they can set a quit date within 15 days. So that is an initial attempt. So if there is a severity, means they have a severe dependence, there is a less chance they might quit in the first attempt, but still the setting a quit date is very important so that they are psychologically prepared for it. And also a brief thing about how they have to do and what are the means. So there are two methods we follow. That is quick turkey method. That is in that cold turkey method. In that people can quit on the first day itself. Or the second is tapering it down and gradually decrease and quit. So it is their choice, and usually the people who have earlier success, we suggest means they can choose either of it. Otherwise, we say that it is better to decrease and then quit. So for that, quit date becomes most important. On that day, and before that, we provide two supportive calls. So after the first call, there are 1 year support system that we provide. So in the first month, it is intense. That means before the quit date, around 3-4 days back, we provide a supportive call. There we say how the withdrawal symptoms, and we explain about the withdrawal symptoms and how to manage those things, everything. And we emphasize the quit day as a very important day, and it is a very important milestone in their life. So on the quit date, again, they get a call whether they are able to make a decision and they are able to stick to it. And 1 week after the quit day call, so there we see whether they are really able to quit it. So sometimes they may be able to reduce it and they are not able to quit it. Sometimes there might be a relapse, but still our support system continues. And if they are successfully quit it, then there will be a 1 month, 3 months, 6 months, and 9 months and 1 year calls. So this will be a follow-up supporting calls. So during all these calls, we become a support system to them in order to manage their cravings and how successfully they can quit it. So there will be a motivation enhancement therapy will be provided, and different techniques is provided for craving management, all those things. And at the same time, we do a referral services to the means if they wish to quit and they are not able to quit it only by counseling, and we insist to take a general physician or a psychiatrist help, where they can include a pharmacotherapy. So we usually do not prescribe or do not provide a pharmacotherapy what call. It is not in our limitation. So then as I mentioned earlier, there will be a referral services. This will be a very important role to the people who are wish to quit and also have a comorbidities. So it is very important for the person to be in touch with psychiatrist, as well as the person may not be able to travel frequently or be in touch with the psychiatrist at that time at in a very frequent way, but they can pick up a phone and they can call and take a counseling and support system from tobacco quitline services, so that so referral services, as well as they are able to reach as and when they need it. So that is a advantage of tobacco quitline services to the people who wish to quit tobacco. Here, one of the barrier that we face is, means when we start following up, many a times people might not pick, or they might feel like it is not a proper time, so they might reject it. So many a times we assume that they are not able to quit it, that's why they are not picking. So we insist that even whether they quit or not quit, and as earlier mentioned, people needs a frequent attempts. So it is okay to fail, but succeeding is important, effort is important. So we emphasize on receive, means to receive a call, or if not, they also can reach to us, and we provide us a constant one single counselor, so they can be able to reach to the same counselor whenever they call. So they can ask the counselor name and they can take a counseling from the same person. Next slide. Yeah. So this year the whole agenda or World Health Organization's theme for World Non-Tobacco Day is to commit to quit. So I request, means if there is a caregivers or the people who are using tobacco and who wish to quit, they can reach to us by calling, and also they can make a audiovisual story of your quit journey and send to us in antiquilnimans@gmail.com. So please note down this email address as well as the toll-free number. Both are important, and with respect to the techniques, how to quit and what are the techniques involved, why it is, all those are explained in Dr. Akank's presentation. So I'm not going for a technical aspect of it, and I'm open for questions.
Thank you, Sudarshan, for briefly summarizing the services that are provided through the quit line. And I think this is something that caregivers and patients can possibly look at utilizing this service that is available.
Yes.
We will come back to questions, and questions can be addressed to both Lekansh and to Sudarshan, and you can also type them on the chat. So while people think about asking their questions, I have a question to Lekansh. So Lekansh, what you have mentioned briefly that while patients are symptomatic, probably it may be difficult. So what do you think is the appropriate time? When do family caregivers approach this as a problem? When should they discuss this with their patients, or should they discuss this with the doctors? At what stage do you think they should do this?
Thanks, sir. So it depends on the patient, sir. For example, if somebody is having a first episode of illness and the treatment is just started, I would personally say, although there is absolutely no evidence for it, and very many people might not actually agree, I think till the psychosis or all the disturbances in the behavior are taken care of, I think the discussion about stopping smoking or whichever form of tobacco should be delayed till then. But if there is a patient who is on medicines, there are some small symptoms, some very insignificant symptoms which are still there. I think in that case, we need not delay our discussion about about quitting.
One other question, Dekansh, I was thinking, who prescribes these medicines? Should caregivers approach the psychiatrists who are seeing their wards, or should they can they meet a physician and they can prescribe these medicines? And are these medicines available, say, for example, in the district mental health program or the primary health care centers, or in, say, for example, Jan Aushadhi Kendras?
Right, sir. So to the first question, there is no legal reason that other doctors cannot prescribe. And this is a bit funny right now. So 2 mg is an over the counter, just like somebody takes Crocin, somebody takes paracetamol for a headache or for fever. Similarly, one can actually walk to the chemist and ask for nicotine gums of 2 milligrams strength. But 4 milligram technically has an RX symbol on the top of it, which does mean that it should not be given without a prescription. Although it would be rare to find a shop which is not ready to give nicotine gum 4 milligram just because there is no prescription. So that's about the gum, and the patches also are more or less similarly available especially for the two medicines which have to be swallowed, the varenicline and bupropion. I think it would be safe to take it from somebody who has experience of using these medicines, because bupropion is ultimately an antidepressant which is used for other things. It's just that it also works for smoking cessation. So I think it need not be a psychiatrist. It can be a primary healthcare doctor, but if the doctor knows about bupropion, that would be a safe thing to do. Are they available? I think at least the nicotine replacement gums and pastils must be widely available. Bupropion and varenicline, I don't think they would be available at smaller centers or even smaller places, shops. I'm not very sure of the free medicine availability as a part of DMHP, sir. I don't have exact answer to that.
Dr. Jagdisha has a question about care. Sir, do you want to unmute and ask the question? Sir, you are muted.
No, I was trying to unmute and it didn't let me unmute, so I had to type. It's a question to Lekhansh and Sudarshan both, maybe to Lekhansh more. Frequently we hear family members get into quarrel with persons with mental illness, asking them to stop or reduce smoking. Does that help for the person quit smoking? And if it does not help, what would you advise as a behavior that the family member should follow to get a better success rate of the person quitting?
Thank you, sir. I'll go first, Sudarshan, and then I'll bring you in. So that is a very difficult question to answer, sir, because there is no real research to say which of the two work. Now, if you ask me, in Indian scenario, it depends on what kind of a relationship the particular caregiver has with the patient. A nagging mother who is otherwise caring and is putting her full force behind the son or the daughter to quit using tobacco, I think is better than a mother who is not really paying any attention that there is also one more problem other than the severe mental illness. So I will not blanket, generally, I would say that it's bad idea for families to be a bit more authoritative, to be a bit more persistent. But if it is leading to severe fights and that is becoming a reason for the patient to say, now I don't want to even talk about smoking, I will smoke, do what you can do, I think that kind of a scenario should be avoided. That's what I can say about it, sir.
So is it that I mean, if a person says, I don't want to quit on the face of it, is there anything that the family members can do to get him to at least talk about it?
I think if usually in the clinic, when we find this kind of a resistance, we step back a bit. We stop talking about quitting. We just say, okay, you think you cannot quit right now. Well, that's okay. How about reducing it? Even reducing it by 1 cigarette. What that allows is the door remains open for you to keep talking. So that is one advice I would give to family members, to first start talking about decreasing it before bringing up the issue of quitting. In our scenario, something coming from the doctor seems to carry much more weightage than family. So therefore, having a word with the doctor and telling the doctor that you should also address this would also be a good idea. So Darshan, you can go ahead.
Yeah, in addition to those, few of the things means we psychoeducate the caregivers with respect to, means there might be many quit attempts, and the person might have genuinely put an effort to reduce it or quit it, and he might succeed it. So we insist, along with persistent effort, also encourage them and recognize their effort. For example, the person has able to quit it for 15 days or for a month, and recognize it and need not to nag when they start it. Means if they do not recognize their effort and their success of a small, even if it is a small success, and only nag, then it is going to create a worse scenario. Instead of that, it is better to appreciate when they put effort, and along with what is that, the quit attempt. So persistent is okay, need not to nag, but at the same time recognizing their effort and rewarding is also important.
Basically, what both of you are saying, that don't do anything which will make this person stop talking about smoking and say, as Lekhan said, I will smoke, do whatever you want. So that shouldn't happen. So it is always, you should know that you should do just as much as the door for further discussion is open, but never get to a stage where the person gets really he doesn't want to stop just because you nag.
Can you just add one thing, Kippy?
Yeah, sure.
So sometimes as family members, and as Dekesh pointed out, it's a very difficult situation to be in many times. Sometimes there are other things that family members can actually help with. But sometimes the smoking becomes the thing that prevents them from actually focusing on other things. So sometimes talking about family members and creating a better relationship by focusing on things they can do together might set the stage for a better quit attempt later down the line. So that can also be done as a way to take somebody's focus from a distressing situation and move it on to something that is a little more achievable and something that the other person is ready to do rather than something they are committed not to. So that's again one more approach.
So are there any questions? Because we have not heard from the caregiver group. So if there are questions or if there are issues that you think were not addressed, you could please raise them. So I think Lekansh, one other topic was the e-cigarette topic. So do you want to address that in any way?
Yes, sir. So one interesting piece of information is now we can talk about e-cigarette without breaking a law, because for a long time discussion about e-cigarettes or research on e-cigarettes in the country, even in academic setups, was banned. So e-cigarettes are a new technology. To an extent, one could call it new. The only thing that they do is they give nicotine, just like we were giving nicotine through chewing gum, we were giving it through patches. Now we are talking of giving it through smoking. The rationale for them is, or the reason why it is considered a safer choice is that most of the harm that comes because of nicotine is due to the way nicotine is used. For example, cigarettes, there are a lot of other things which cause harm. Nicotine by itself may not be causing that much harm. So that is the whole rationale for promoting e-cigarettes as a good way of nicotine delivery, which should eventually lead to a quitting attempt. This must be kept in mind. All the research as of today is for using e-cigarettes just as a transition, just like we are using nicotine gums or patches to eventually take the patient to a stage where they can stop using. So that's the background with of e-cigarettes. I am not very aware, although the rules have changed, I am not aware if affordable, safe preparations have become freely available in the country. I think it might take some time. So yes, it would be an option which would open up once that happens.
One other question which I had, Dekansh, was, and also Sudarshan could add, was sometimes people use both chewing and smoking. So as a family caregiver, what should be the priority when I have to address this issue?
Since it's difficult, I'll ask Sudarshan to go first.
Okay, so usually we say that means we give a preference to the person who wish to quit, and also we say that make sure other things are not increased. So you are going to keep that as a staple, and when you are putting effort to quit the first one, means whether it is a smoking or chewing, whichever they prefers to quit first, they can go ahead, but make sure other is not increasing. So then they can go for the second one to quit.
Okay, thanks, Sudarshan. And do we have any more questions? So also I would invite if there are any contributions that Dr. Deepak or Dr. Jagdisha or Dr. Shiva would want. Yeah, go ahead. Yes, go ahead, madam. Yeah, we can hear you. Go ahead, madam.
Sir, can you
introduce yourself? Introduce yourself and
myself is myself Rama Ganeshan, sir. I am a caregiver. So can you give the toll free, that quick line toll free number, whatever the counseling number?
Yes, please.
1800
1800
yes
11
11 yeah
2356.
2356. Okay, thank you, sir.
okay. Any other questions? Any contributions from Dr. Deepak, Dr. Shiva, or sir, Dr. Jagdisha?
Want me to go, KP?
Yeah, you can.
One thing is that, as Lekanch and as Sudarshan pointed out, it can be difficult, and it requires patience, and it requires a long view rather than a short-term view. So from a caregiver's point of view, sometimes the need is to set up the conditions to quit later down the line rather than do it immediately. Sometimes things can go back and forth, as Lekanch pointed out quite a few times. Sometimes people may reduce the number of cigarettes, go back up, reduce again. So it's important to kind of think about what the goal is rather than get frustrated with the fact that somebody has increased their cigarettes again. And sometimes changes in mental illness, stress, these can themselves cause people to increase their smoking. During the pandemic, many people have increased their cigarette use. Some have decreased, but many have increased. So it is important for family members to think about helping the person cut down. And as Dekansh pointed out, cutting down is an important goal to think of. It's not failure to cut down. And when discussions get particularly difficult, that is when involving a mental health professional is a good idea. So that at least some of that discussion is outsourced to somebody else who the patient may accept as having more authority. And when there are fights, and sometimes it can be quite significant because it can be about, is it 10 cigarettes, 12 cigarettes? It's probably better to lose the fight in the short term and be able to talk about things calmly rather than win. So I think that is an important thing to keep in mind, that it's not so much the role to be a enforcer as opposed to a facilitator. Thanks, Gil.
we just have 2 or 3 minutes for people, if any, want to share any challenges that they have experienced while managing their relative or family member who has had trouble with quitting. So if you have any experiences of challenges, you could share those as well. Anyway, if none, then probably any last word from you, Dr. Jagdisha, sir? Okay, so, sir? Okay, so I think on behalf of Psychiatric Rehabilitation Services, we would like to thank both the resource persons, Dr. Lekansh and Sudarshan, for conducting this program and responding to several queries, though we didn't have significant participation from the caregivers, but I think we thought this was pertinent to address, and for a long time we had not taken this up as a topic in the forum. So we would also be having further such programs. Maybe Deepak would keep you posted on what would be the next program in line, and probably we will continue this conversation on a monthly basis. Over to you, Deepak.
Yeah, as KP said, we'll have our next one on the 23rd of next month. We'll shortly inform you as to what it is. We're still in the process of arranging it. And I just again like to thank Lekansh and Sudarshan. It's nice to see both of you. And it's been a pleasure talking about this topic again.
Deepak and Lekansh, you see a mention of
a similarity in the
more such
hairstyle
programs
and
in
the,
addiction.
yeah. Okay.
Right.
Thank you. See you.
Thank you. Thanks a lot, sir.
Bye.